Hi everybody, and welcome to our module on stimulants. In this video, we're going to talk about these four substances listed on the screen. All of them are stimulants, meaning they activate the central nervous system. And this is in contrast to drugs that depress the central nervous system like alcohol and barbiturates and benzodiazepines. We'll start with cocaine. And what you always want to remember about cocaine in terms of physiology is that it has two key effects. First of all, it is a local anesthetic. It blocks sodium channels. If you look at the bottom of the screen, this is the chemical structure of lidocaine, a commonly used local anesthetic, and this is the structure of cocaine. They are somewhat similar, and in fact, cocaine was one of the first local anesthetics ever discovered, and later many others like lidocaine were discovered as well. The second effect of cocaine that you want to remember is that it inhibits the reuptake of monoamines in the central nervous system. So what are monoamines? Monoamines are neurotransmitters that have a ring and an amine group hanging off of them, and there are several of these. They include dopamine, serotonin, which is also called 5-hydroxytryptamine, and norepinephrine. The reuptake of all of these monoamines is inhibited by cocaine. That means that their levels go up in the synapses of the brain, and that's what leads to many of their physiologic effects. Importantly, when the levels of dopamine and norepinephrine in the brain go up, there will be sympathetic nervous system activation. So an easy way to remember the physiologic effects of cocaine is to just think of it as an on switch for the sympathetic nervous system. That's what it does by raising the levels of these monoamine neurotransmitters in the brain. Here's a slide from one of our videos in the neurology section on the autonomic nervous system. And in those videos, I talk about adrenergic synapses where norepinephrine is released into the synapse. And in those videos, I talk about how the amino acid tyrosine is used to synthesize norepinephrine, which is released into the synaptic cleft and can activate alpha or beta receptors. Well, what cocaine does is it blocks the reuptake of norepinephrine and also other similar monoamine neurotransmitters like serotonin and dopamine. And for this reason, it raises the level of these compounds in the synaptic cleft. Amphetamines also do this, and we'll talk about amphetamines later in this video. So the reason people abuse cocaine is because cocaine intoxication feels good. These are lines of cocaine on the screen here. Many people snort these to get high on cocaine. And when they do that, they have increased energy. That's because it's stimulating. They have less need for sleep. They feel hyper alert, and they often feel euphoric. And all of these effects are because of increasing levels of those monoamine neurotransmitters in the brain. There are also some downsides to cocaine intoxication. These don't happen to every patient that uses the drug, but they do happen to some, and they often lead to an emergency room presentation, so you need to know how to recognize these effects of cocaine intoxication. First of all, patients who use cocaine may hallucinate. Classically, cocaine leads to tactile hallucinations. The classic complaint of a patient who has taken too much cocaine is a feeling like bugs are crawling on my skin. Patients who take cocaine can also develop a fever. There are a couple of reasons for this. First of all, these patients are hyperactive, so there's lots of muscle activity, and that can raise the temperature. In addition, there is central dopamine release, so for both of these reasons, patients who come to the ER intoxicated with cocaine may have a fever. Cocaine can make you anxious, it can even make you paranoid, and in some cases, this can mimic psychosis. But remember, there are three elements of psychosis: hallucinations, disorganized thought, and delusions. These patients will usually only display hallucinations and not other elements of psychosis. And the treatment is benzodiazepines, which is a CNS depressant, and it will counteract the effects of cocaine. Some of the signs you will see among patients who are cocaine intoxicated all involve sympathetic nervous system stimulation. Remember, cocaine is an on switch for the sympathetic nervous system, so there will be stimulation of alpha and beta receptors. First of all, the pupils will usually be dilated. This is because of the sympathetic nervous system fight or flight system activation. You can also see tachycardia and increased blood pressure. Chest pain is a very common complaint among cocaine users. There are a couple of reasons for this, and they all relate to the fact that the sympathetic nervous system is activated. First of all, there's an increase in myocardial oxygen demand. That's because the sympathetic nervous system activation leads to tachycardia and a rise in cardiac contractility. It also leads to hypertension, which represents an increased afterload on the heart. In addition, there is a fall in oxygen supply to the myocardium because of coronary vasoconstriction. Therefore, you get a mismatch between supply and demand, and that leads to angina. In addition, cocaine can cause thrombosis. It can cause platelets to stick together and thrombus to form, so cocaine can lead to a myocardial infarction. It's rare, but it sometimes happens, and this is the way that patients die when using cocaine. They have a myocardial infarction and they get an arrhythmia, and that leads to cardiac death. The treatment for chest pain in a cocaine user is very different from the treatment of other forms of myocardial ischemia. The mainstay of treatment is benzodiazepines. As I said before, this counteracts the stimulating effects of cocaine It's sedating and calming, and it diminishes the cocaine-related stimulating effects. We usually give an aspirin to lower the risk of thrombus formation, and then finally, you need to avoid beta blockers. If you administer beta blockers when the sympathetic nervous system is activated, you will have increased and unopposed alpha effects, and this can worsen hypertension and chest pain. So even though we normally give beta blockers to patients with the regular kind of angina, you don't want to give beta blockers to a patient with angina from cocaine use. There is a withdrawal syndrome that can occur among chronic cocaine users. It's not very serious and usually not life-threatening. If patients are using cocaine regularly and they stop, they can get depressed and tired. They can have trouble concentrating and they can be sleepy all the time. Basically, this is a reversal of all the stimulating effects of cocaine. Unlike other forms of withdrawal, like alcohol withdrawal, this is usually not dangerous. All right, moving on to our next stimulant, let's talk about amphetamines. Just like cocaine, these drugs are stimulants that increase central nervous system activity. All amphetamines have a modified form of a molecule called a phenethylamine. This is one shown at the bottom of the screen here. It's got a benzene ring attached to an amine group, and a modified form of this molecule is present in every type of amphetamines. There are a number of different subtypes. They're all stimulants. They function as indirect sympathomimetics. I'll show you this in a second. And what they do is they raise levels of dopamine and norepinephrine in the central nervous system, and that's why people abuse them, because they are stimulating and they make them feel hyper alert. If we go back to our slide here, amphetamines can block the reuptake of norepinephrine and dopamine just like cocaine does. In addition, amphetamines promote the release of dopamine and norepinephrine, so they are highly stimulating by significantly raising the synaptic levels of the stimulatory neurotransmitters norepinephrine and dopamine. A patient who is intoxicated on amphetamines will be hyper alert. They won't need to sleep. Their sympathetic nervous system will be stimulated just like patients who take cocaine, so they will have tachycardia and hypertension. Their pupils will be dilated. They can develop fever and agitation just like cocaine patients, and they can develop chest pain just like cocaine patients. Rarely they can have seizures. This is uncommon, but it does happen. And just like cocaine, it's treated with benzodiazepines. Basically, the clinical syndrome of an intoxicated amphetamine patient is very similar to the clinical syndrome of an intoxicated cocaine patient. Moving on, let's talk about caffeine. Caffeine, as you may know, is a substance found in coffee and other caffeinated beverages, and Dr. Ryan himself is a major abuser of this substance. Caffeine's chemical structure is called a methylxanthine. This is its structure shown on the screen here. It's got a 5 and a 6-member ring, and you can see the caffeine structure is very similar to the base adenine, which is found in the nucleotide adenosine. And if you know that, that's an easy way to remember that the way that caffeine works is by antagonizing adenosine receptors. In the central nervous system, this leads to the release of dopamine and norepinephrine, and that's what's responsible for caffeine's stimulatory effect. In addition, there are some adenosine receptors found in the kidneys, and for this reason, when you drink caffeine, there's renal adenosine receptor blockade, and this leads to a mild diuresis. So if you drink lots of coffee, you will urinate a lot, and there are 2 reasons for this. First of all, you're drinking lots of liquid in the coffee itself. In addition, there is a mild diuretic effect of caffeine. In the cardiology video on stable angina, I talk about chemical stress tests. This is a way to administer a stress test to a patient who cannot walk on a treadmill. And one of the ways you can do this is by administering intravenous adenosine, which functions as a vasodilator. This will induce a phenomenon called coronary steal, which I talk about in the stable angina video. You should be aware that the effects of adenosine are blocked by caffeine. That's because, as I told you before, adenosine has a methylxanthine in it, and caffeine is a methylxanthine. So if a patient has had coffee and they come in for a chemical stress test, they won't be able to have their chemical stress test because the intravenous adenosine will not work. The same is true if a patient is on theophylline. This is a COPD drug. It is also a methylxanthine, and it will block the effects of adenosine if used for a chemical stress test. Lastly, we'll talk about nicotine. Nicotine is an addictive substance found in tobacco. It activates nicotinic acetylcholine receptors and works as a CNS stimulant, and it activates the sympathetic nervous system. Shown on this slide is our map of the autonomic nervous system that I describe in detail in the videos in the neurology section. But by way of review, nicotinic acetylcholine receptors are found between the pre- and postganglionic neurons in the sympathetic nervous system. In addition, you can find nicotinic receptors in the adrenal gland in the adrenal medulla. So when these receptors are activated by nicotine, this basically turns on the sympathetic nervous system. You get release of epinephrine from the adrenal gland, and you get activation of the neurons in the sympathetic nervous system. There are nicotinic receptors found in the parasympathetic nervous system as well, but it is the sympathetic system effects that dominate, and that's what you want to think of when you think of the effects of nicotine. Because of its central nervous system effects, nicotine is highly addictive, and for this reason, people find it hard to quit smoking, and when they keep smoking, they can develop lung cancer and emphysema. If patients who are smokers do quit smoking, they will go through nicotine withdrawal, and the symptoms of nicotine withdrawal are shown in this slide. First of all, patients who quit smoking get very hungry and they usually gain weight. They also often usually go through a period of depression. In addition, they have sort of a relative central nervous system hyperactivity that leads to insomnia, irritability, anxiety, difficulty concentrating, and restlessness. These are all symptoms of the central nervous system just being out of whack because you've removed the nicotine stimulus. The symptoms peak in the first 3 days after a patient quits, and they subside in 3 to 4 weeks. So it's this first month after quitting smoking that is the hardest to get through in terms of withdrawal symptoms. For your boards and also for real life, you should understand how to counsel a patient who is a smoker to get through smoking cessation. First of all, as I mentioned before, the primary barrier is the addictive qualities of nicotine. The first thing you want to do when helping a patient quit smoking is assess barriers to quitting. This is a buzzword. What this means is you want to discuss the benefits of quitting and address the patient's concerns. Find out what might be keeping them from quitting smoking and see if you can help talk them through that. The second thing you want to do, and this is also a buzzword, is to set a quit date. This is a specific date a few weeks away in the future, and this is going to be the day that the patient completely stops smoking. You want to get them ready for a quit date, get it set in their mind. This is also the date when you can begin to support them to help them stay free of cigarettes. The rate of smokers successfully quitting smoking is relatively low, and most people who do successfully quit usually fail a couple of times before they succeed. But there are a couple of medical therapies that you can recommend to your patients which can help increase the likelihood that they'll be able to quit smoking. The first one is nicotine replacement therapy. So there are nicotine patches and nicotine gum. These don't do anything to break the addiction to nicotine, but they do help the patient to stay free of smoking cigarettes, and then later they can wean themselves off the nicotine replacement therapy. Second option is the antidepressant bupropion. This was shown in clinical studies to increase the likelihood that patients would remain free of smoking. It works by blocking the reuptake of norepinephrine and dopamine, and I talk about this more in the video on antidepressants. The last option is one that's very popular these days. It's a drug called varenicline, which goes by the trade name Chantix. This drug has a very interesting mechanism of action to help patients stay free of smoking. It functions as a partial nicotinic receptor agonist, so it has some agonist effects and some antagonist effects on nicotinic receptors. Because it's an agonist, it will limit the withdrawal symptoms and make them milder, and that helps patients to not go back to smoking. Because it's an antagonist, it blocks the effects of nicotine, so if the patient does cheat and smoke, they won't get as intense a reward, and this will make it more likely that they won't continue to smoke and will go back to being smoke-free. The main adverse effects are nausea and sleep disturbance. Patients who take this drug often have insomnia, and they will often tell you that they have very weird, abnormal dreams. Now, when this drug first came out, there were reports that it was associated with depression and suicidal ideation. Those have subsequently been disproven, and the FDA has removed any warning that varenicline may cause depressed mood. But if you read some older textbooks, you may see this, so I just wanted to make you aware. And that concludes our module on stimulants.